knees against the board as best as you can. You're gonna want to move your feet towards the board as more too. Okay, good. And then you can hold the bucky or this stand. Okay. You don't have to squat yet. I'll tell you when, because I don't want you hurting. So this is gonna be your Rosenberg. This is for the intercondylar fossa. Okay. And so
that's this one right here.
Oh yeah.
You'll see. There's a couple of them. You're not gonna be able to do this one with the phantom.
Okay.
I'm just showing this for you, or for you guys, because this is gonna be more common. I'm sure UCI does Rosenberg.
Yeah.
And I know Kaiser does. And I want to say Mission does sometimes, depending on the joint doctor, but we'd have to confirm with Steven. He would probably know better. So anyways, this is going to be your weight-bearing ICF, okay? It's really important that you have your patient either hold this pedestal. Some of them are a little further away from the board, so they can't really hold on to this. So I'll have the patients hold the back of the board, okay? And then I would use the little box at the center of the board for positioning. So for Jessica, because we're doing both knees, I would have both knees just on the edge of that box when she goes to put her knees against the board. If it was one knee, you're going to want to put it directly in the center of that little box. And I'll show you guys once she steps down where the box is. Okay? So Jessica, I'm going to have you grab either the pedestal or the bucky. And then you're gonna squat down.
How far?
Right there is good. So this is about as far as you want your patient to go. And you do want their shins a little closer than further back because you don't want them leaning. That'll change the view, okay? You also wanna make sure that their knees are straight on and not turned because it shows up, any little rotation shows up immediately on x-ray and you won't get that nice tunnel. And then you don't want Jessica to bend down too much because you can stand up now because yeah. So some people have really thick thighs or a really thick bottom. You don't want them to scoot down so much that now their soft tissue is getting in the way of the ICF, and then you guys are just not going to be able to penetrate it. So if they are a little thicker, I'll just have them not squat down so much because you don't want to X-ray their bottom.
Yeah.
Okay. And I tell my patients that too, and they get it. So now I'm gonna have you step down.
So still 40-inch SID and then CR just at the back of the ICF. Is that correct?
Yes. So for the ICF, you're gonna go right below where the bend of the knee is because you don't want it to go through where the gap is.
Okay.
Because it does sense that it should shut off the AUC. So you go right below where you still have.
So just below. Okay.
You still have that thick bony anatomy. So it doesn't automatically shut off. Yes, JP.
Separate question. If you were to throw a 10-degree angle on it, does that like open a joint or does that like help like the patient?
It depends on what the doctor wants.
It's like a doctor. Okay.
Yeah, because I've seen the 10-degree angulation where they actually have like a little compass and they're measuring to make sure it's exactly 10 degrees. And it just depends on what the doctor needs. I was just gonna show you guys straight on initially. But yeah, sometimes the doctors might want to throw an angle, but I'm not gonna, I'll let you guys learn that in clinical.
So it doesn't even matter if it like opens a joint that angle doesn't open a joint?
Well, I know the only time that I did it, a doctor was performing a study, so they didn't necessarily have the exact, reason. They were comparing the 90 degrees to the 10-degree angle. So I would have to look it up. I'm not totally sure.
Yeah.
But I know that when I was a student, that was a study that the orthopedic doctors were performing, so it wasn't used, I guess, as normally. Yeah.
So for this class, we're not going to consider the type of patient like either fluffy or skinny. We're not going to worry about angulation.
Not for Rosenberg.
Okay, but for AP and oblique.
Yes.
Okay.
But we'll get there. Don't get ahead of me. But for weight bearing, it should always be straight on, right?
Yeah.
Because you're seeing what the compression is. You don't want to be angling, except for in JP's case where that doctor did want a 10-degree angle, but you guys don't need to remember that part. Okay. Just if it's weight bearing, just straight on to the board. Okay. Let me change this because now we're gonna do lateral